All right. I am excited for today. Good afternoon, everybody, and welcome to Recovery Live. C4 Innovations is absolutely thrilled to bring you another Recovery Live event. And as always, we bring top tier folks, interesting and challenging issues and strategies that help peers and non-peers alike in improving the lives of others who experience behavioral health challenges. So at C4 Innovations, or C4 for short, we are committed to advancing recovery, wellness, and housing stability for people who are marginalized. And we are committed to reducing disparities, achieving equitable outcomes. We engage, support, and partner with service organizations, with communities, and with systems to develop and implement research-based and evidence-based solutions that are person-centered, trauma-informed, and recovery-oriented. You can learn much more about the work C4 does by visiting our website at c4innovates.com. And feel free to follow us on Twitter, Facebook, LinkedIn, and YouTube if you're so inclined, because we're all over those sites as well. Today's Recovery Live events are, just like those in the past, very interactive. You engage directly with our presenters and each other through the live chat box. And I think that chat box is pretty active already. And the speakers are going to share some of their initial thoughts, and then we're going to have them answer some questions that you guys raised during this event. So all of you are in listen-only mode at the moment, and you can introduce yourself. You can pose any questions, share ideas, particularly links to resources, or, and this is just as important, let us know about your tech difficulties by typing them into the chat box. And if you'd like to send a private message to the host, you got to make sure that you use the drop-down arrow and then select all panelists in that chat box. If you don't do that, your message goes to everybody. This will get your message directly to them, but we do want everybody to be able to participate in the chat to the extent you feel comfortable. And to do that, make sure that you have the option hosts and attendants. And I think that's the default setting anyway. And that way your message goes out to everybody. To access the chat, you just click the word chat on your screen and that chat box will pop out. You can resize it if you need to. Click and drag it to the side, and it'll always stay up, but mostly out of the way. Today's event is going to last 1 hour. It's being recorded. And of course, we'll be sharing that link with everybody who's registered, whether or not you attended the event. It's also going to be available on the C4 YouTube channel listed on this here slide. So if, as you are listening to this content, you feel like your organization could benefit from technical assistance around this particular topic or any other topic that has anything to do with recovery, behavioral health, addiction, mental illness, etc., please email us at training@c4innovates.com, because we are more than happy to discuss your needs, brainstorm some strategies and potential solutions, and then work together with you to determine the best technical assistance available to meet your needs. I mentioned earlier that C4 and Recovery Live events work to bring you top tier experts. Once again, no exception, because we are beyond fortunate to have some really amazing folks today, and for a really interesting discussion on harm reduction. The title is "Where's the Line? Defining Harm and Harm Reduction." And I'm really pleased to introduce today's speakers, because the truth is I personally benefited from harm reduction approaches prior to my entering recovery. And I am convinced that those approaches helped me save my own life and kept me safe from some of the potential diseases that circulate within my community. And it kept me that way until I was actually ready to make some changes in my own recovery. And because of all of that, I am just really excited to listen as these three speakers discuss and talk through this topic. And we're going to start off today with Yarelix Estrada, the city research scientist with the New York Department of Health and Mental Hygiene. We'll turn next to Shannon Knox, the Director of Training and Education with the Los Angeles Community Health Project. And then Donald McDonald, the Chief Recovery Officer at All Sober, is going to wrap us up and take us home today. So now we're just about to get started, but before we do that, one thing I want to do is make sure that I'm able to alert everybody to what's coming up next, both in terms of our Recovery Live events and what is happening within C4 Innovations as we move forward. Bina, next slide, please. So the July 22nd event is going to be on recovery housing, and I am working right now to secure the speakers for that. If you're interested in recovery housing at all, I strongly encourage you to check us out and stop by on July 22nd. You will not be disappointed. Also, for those of you who are here today, a recording of today's event is going to be available pretty quickly, usually within a week, on C4's YouTube channel, and you can see the address below. Next slide, Bina. And I wanted to point these upcoming course opportunities out because I think some of these are likely to be of interest for participants in this event today. The June 24th, Bringing Racial Equity Strategies to Recovery Support Services. That should be a very well-attended event. There's a two-part webcast series on parenting and recovery. It starts June 30th. That's part one. Part two is July 14th. Racial Equity in Recovery 101. This is addressing race-related barriers in recovery support services. Another live online course starting July 12th. And then Leading with Lived Experience, Building Capacity for Peer-Run and Recovery Community Organizations. This is live online learning community, and that'll start in September, September 21st, 2021. That's also one of the areas of my great passion. I have spent a long time working with organizations to build capacity around peer support, peer run, and recovery community organizations. So I hope that you will join us for some of those. And with that, let me get to what you guys are all here for, because it sure isn't to listen to me. How this is going to start is I'm going to pose an opening question, an individual opening question to each of the speakers. And then once that's done, we're going to go through a series of additional questions. And most importantly, from all of you, any questions that you have, pop them in the chat box. Our wonderful tech support, Bina and Melissa, will get them into my hot little hands, and I will then pitch them over to Shannon and Yarelix and Donald as we get to the Q&A portion of today's discussion. So let me shut up now and turn to Yarelix. Yarelix, we know that drug use is widespread and many, many people use them. Can you talk about why you believe that people use drugs?
Sure. Well, thanks so much for having me, and thanks to everyone so much for being here and for being part of this talk. Yeah, so I think there are a wide number of reasons why people use drugs. I first got involved in harm reduction because I was working doing nightlife harm reduction, which is just peer support and making sure that everyone who is intending on using whatever substances they're planning on using are using them safely. And the predominant reason why they're using in that setting is for pleasure, is for fun, is for enhancing their connections with other people. It's to enjoy, just enjoy the experience that they're having in that heightened state. But, we also recognize that there are other reasons why people use, and I think that tends to be the dominant narrative around drug use, that some people use to escape from life or to numb themselves, or which could be a valid situation. And I work in overdose prevention, and what I see with a lot of the folks that I work with is people who have been historically left out of the systems of care that this country tends to offer. So they don't have housing, they don't have health care, they don't have family, they don't have, different ways of coping that might be healthier than using drugs. So instead they turn to using drugs just to get through the day. And I think that that's also a valid reason, because if there's someone who doesn't have a way of getting comfortable or feeling pleasure for a small period of time, then having drug use as the way of getting through the day is a valid reason to use. And there's also reasons in between that, right? Some people use it as a way to perform better at work. Other people use them as a way to relax when they get home from work. So there's definitely a lot of reasons why people use drugs, extending from pleasure to having some time to have comfort for themselves. And sometimes we know that that can escalate into chaotic use, which is when, you know, hopefully there are systems of care that can better support those folks.
Yarelix, it's awesome. Thank you. That's a great way to start us off. And let me just turn to Shannon and Donald really quick. Anything that either one of you want to just add to what Yarelix just shared before I come at you with an individual question?
I can certainly share why I use drugs. You know, it was culturally normative in my community first, and I had easy access to alcohol, tobacco, and drugs at a very young age. But I've discovered through my healing process that that I had a lot of childhood trauma, and I discovered later in life co-occurring mental disorders, and just a whole lot of problem connecting with folks because of that trauma. So, you know, alcohol, tobacco, and drugs really helped me connect with a group of peers, helped to ease some emotional pain. So I am that vulnerable group that Yarelix mentioned, you know, having those vulnerabilities and the risk factors associated. So I experience pathology as a minority of people do who use drugs. And for me, care was available. And I'm deeply gratified. It's not for everyone though, but that's.
That was awesome. Thank you. Shannon?
To speak to the population that we work with and that I've worked with for most of the time is like unhoused people experiencing homelessness. We find when we ask them, you know, why they use, it's usually a tool to get through the day, to go to sleep, to stay awake, you know, to stay awake when there's not a safe situation for them to go to sleep. They'll use speed, you know, sometimes that can lead to psychosis, but basically just using to cope with daily life of being unhoused.
It's really helpful, Shannon. And, you know, I would just add, I probably have very similar story to Donald's. And my substance use really was a way to be accepted. And later, it was also a way to have access to friends, access to events, because I had what people wanted. And you know, there's a piece of sort of popularity around that if you have struggled with childhood trauma, if you found yourself isolated, marginalized, and alone in most of the, you know, the conditions of your family and your sort of young life, there's something really appealing about, you know, being the sort of star of the party or the center of attraction because of what you can bring to the table. So I absolutely get it. And I've also used out of pleasure. I've used out of anger, as Yarelix had said. You know, I probably ran the gamut of reasons to use. I think, you know, there's a lot of reasons, and I think we just barely started to scratch the surface there. Shannon, there's a ton of misinformation out there about harm reduction. Excuse me, and even the National Harm Reduction Coalition will tell you that, you know, there's no universal definition or formula for implementing harm reduction. But given the work that you do every day with the LA Community Health Project, can you give us a better understanding about what harm reduction is and what it's supposed to actually do?
Well, the thing is that harm reduction is a term that you can use for, you know, a lot of different scenarios, risk causing scenarios, but risk increasing scenarios, but we particularly work with people who use drugs. And I would say that the way we consider harm reduction is a whole person care approach to improving the health and well-being of people who use drugs without placing any barriers for service provision. So we consider basically the simple retaining of our clients or participants as our benchmark of success. Like they're still here, they're still with us, we're still in communication with them, because through so many other program structures, that aren't harm reduction based placing barriers on these people, we are sometimes the only programmatic entity that they're in contact with. And so for us, harm reduction is retaining people, being open to support them whenever they ask, whenever they need, when they choose, and basically to also help them educate their communities in risk reduction ideas and empower them to protect themselves. That's what harm reduction is to us here at CHPLA.
Shannon, that's fantastic. That's that was just a fantastic response. Yarelix and Donald, anything that you want to add, or do you want to share your own perspective about what you think harm reduction is and should be doing?
Well, for me, from my lens as a person who pursued recovery from problematic substance use and then identified as being in recovery and then entered into the field as a clinician and an advocate, as I started learning more from my public health counterparts and harm reductionists in my community, as we were sitting in tables responding to the overdose crisis, harm reduction from my lens is so much more compassion. The recovery thing was all about like hope, and recovery is contagious. And then that's the kit, that's the tool we bring, that's the hammer we bring, but we were seeing everybody as nails. And if you're not a nail, then I got nothing for you. And then the harm reductionist with whom I worked, it was compassion. And so I see it as a philosophy underpinning policy and practice in a way of life that values humanity and their safety and values their autonomy and choice. And man, I'll tell you, it's improved my practice and my life and my recovery immensely. I'm eternally grateful to folks at the North Carolina Harm Reduction Coalition and my good friend Robert Childs, with whom I worked over the last couple of years. So, yeah.
Donald, that analogy was, it is about hope. Recovery was about hope, but the idea of we got nothing for you. I have big chills from that, because how many times have we had to say that to people? It was just an excellent description, and thank you for that. Yarelix, what's on your mind over there?
Yeah, so I totally agree with both of what Shannon and Donald shared. I guess like the classic definition that folks always say is meeting people where they're at. And I think that just means that harm reduction is not a one size fits all approach. Like harm reduction for each different community looks very different. So for some, like a lot of the work that I'm focused on in New York City is working with communities of color, because those are the communities that are being most impacted by overdose and the overdose crisis that we're seeing. And for them, harm reduction is very different. Some people are, totally about grabbing syringes and passing out naloxone and, doing that. And other people are not. And other people need more of an explanation of why we need to move away from that. And for other people, harm reduction is just giving them water or giving them shoes or, whatever it is that they need at that time. And I, like what Donald said, having that compassion to understand that everyone is in a different place and giving each person what they need in order to stay alive, and also to just not want to completely disconnect, because that's how we lose more people. That's all I would add.
Yarelix, that's awesome. And, just thank you for that compassion alone. Donald's point about this piece of compassion, if you listen to Shannon, it oozes out of her, right? When she talks about the work that she does, when she hits that piece, she oozes compassion and harm reduction. And I don't know how else to describe it. It doesn't sound very attractive, but it's a beautiful thing to witness. So sorry, I got us all off track here, but let me turn to you, Donald. Can you talk about, and I'm basing this, Donald has written an excellent piece, and Donald, I'll let you share the title and where it was published, but Donald did it might be a challenge, but he did an excellent piece on stigma and discrimination. I do a lot of work with stigma. when I read it, it made me stop and think, and then make some adjustments in how I was thinking about stigma and discrimination. It was that impactful. That's why I want to ask you this question, Donald. Can you talk about the difference between stigma and discrimination and its impact and relationship with harm reduction?
Sure. I don't entirely remember the piece, but I do know that I began embracing this concept of unexplored internal biases. That stigma is actually prejudice. You know, it's prejudice, and we all have prejudice. We all have biases. It's neither good nor bad. It simply exists. We all have them. It's a matter of our socialization, our culture, our family, media exposure, what we see at work, and we formulate these assumptions, these stereotypes, these negative biases towards types of individuals, groups of individuals. We all have them. And because we think that they're a bad thing or a dirty thing or a thing to get canceled over, we don't talk about them. And I believe that's the crime. Biases we all have, unexplored biases that turn into practices that impact the quality of the care that we provide for people, that impact the depth of connection, or that result in the absence of compassion or discriminatory barriers to wellness and freedom, to recovery initiation, recovery maintenance, recovery actualization. I had immediate access to treatment. I had robust recovery supports in my community. And because I was a white dude driving a minivan while I was breaking the law, I had no criminal justice system entanglement. So I got those student loans, and I got to go back to school, and I got to become an executive. So I had privilege in the absence of bias against, how I appeared. However, people who use drugs, there's a prejudice against people who use drugs, and therefore we see discriminatory practices. For the longest time, fentanyl test strips and syringes were prohibited items through federal funding. That's changing now, and I'm deeply gratified at the growth, but we got to look back at that alone in the midst of a recalcitrant and deadly overdose crisis. We still were letting bias impact our policy and practice while the body count just soared. And it was an untenable position to have. And so that's to me the difference between stigma and discrimination, or bias or prejudice, the practice, and unexamined biases within individuals and within systems lead to discriminatory barriers and behaviors, and harm connection with folks, and keep folks from accessing the care they deserve and then living a full life. So that's what I'm all about. And because my recovery pathway was so filled with access, born out of my prejudice, born out of my privilege, I've committed my life to trying to address those systems, and trying to encourage folks within the addiction recovery community, within the clinical profession, which draws lots of people in the milieu from recovery, and the peer-based workforce. We bring a lot of strength to these workforces if we explore our biases and don't let those get in the way. And if we don't, we're going to cause a bunch of harm. And we've seen that over the decades. Oh, you're muted, brother. You're welcome.
But it was a spectacular response.
Thank you.
Yeah. So let me just check in with Yarelix and Shannon both on this question. And I don't really expect you guys to go, to have a big, deep, elaborative discussion around it. But from your own perspective, the stigma issue, and as it's connected to harm reduction, particularly, feels to me like one of the biggest pieces of stigma that we deal with. Thoughts on that?
I was going to let Yarelix go first, but I'll just be quick. First off, the work of harm reduction is stigmatized. The work that we do is stigmatized, as you're talking about, with funding not being available to our programs because of the work that we're doing. Secondly, when you talk about discrimination, if you do consider people who use drugs a category of people, like, you know, you would with gender, race, etc., then the drug war has been like pretty much genocidal in how it's been wiping out people who use drugs. And the discrimination factor is what allows it to happen, because people don't like people who use drugs as a category of people. And so I like to change that up and call it discriminatory instead of just stigma, because it defines a whole group of people that are dying at alarming and increasing rates. And harm reduction shouldn't be stigmatized.
Right. Well said, Shannon. I mean it. Well said. I'm sorry, but that, yeah. Yarelix?
Yeah, exactly what Shannon said.
Yeah.
Totally correct. I think when we're thinking about folks who use drugs, there's also just the intersectionality of identities, right? So someone's not only a drug user, they may also be a person of color, or they may also be a queer or trans person, or unhoused. And, you know, and when all those things are compounded, they're just extremely stigmatized and discriminated against. And not just from people. Like I've definitely experienced the hatred that people have towards people who use drugs, and using them as a way to blame them for whatever it is that's wrong in their life, because they don't know who to blame and they're just an easy scapegoat to blame. But we see this through our policies. We see this through institutions. So like a lot of the folks that we work with have said that the hospitals treat them horribly, drug treatment programs treat them horribly, the pharmacists treat them horribly, like everyone treats them so badly. And so it reinforces some of the stigma that they may have in themselves, and thinking like, well, maybe I am these things, you know, because everyone seems to hate me. And then it makes it even harder for folks to have that motivation to want to get help, you know, because like where are they going to get that help? So that's definitely, it's interpersonal, it's in systems wide, it's on policy level, you know, it's found all over the place with folks who use drugs.
Are you saying that it's pervasive and pernicious? Because I sort of think that's what you're saying, and I think that's really accurate. Yarelix, thank you, because you also raised this intersectionality piece around multiple stigmas and how that combines to add essentially insult to injury, or rub salt in wounds, whatever, you know, metaphor or analogy you want to use. You know, when I think about my own past and the things that I have been called in my life that are stigmatizing, they have run from my substance use to the color of my skin to the status of my parental beings, to almost, you know, anything under the sun that people could point to and say he's different. And exclude me, which is what stigma, discrimination, and bias does, right? And we also know that stigma is the #1 reason people don't come for treatment. And it's also the #1 reason that they leave treatment early too, for all of the reasons that you just articulated.
And the #1 reason that often that treatment is inadequate and inappropriate.
Boom.
Yeah.
Yes. Yes.
Right on.
So, all right. I'm going to throw a bomb out to all three of you, because we've got a pretty good understanding now of where the three of you sit in terms of, you know, the harm reduction spectrum. We all are, you know, just sick of the stigma killing our brothers and sisters. It almost killed us. It certainly almost killed me 3 different times, as a matter of fact, before I entered treatment. But here's the elephant that I think is standing not just in the room, but on top of all three of you. Can you guys talk for a minute about this perceived or real friction that a lot of folks feel exists between the recovery community and the harm reduction community? And I apologize for throwing that out there this early, but I think we want to jump into this and talk about it a little bit. Thoughts?
Well, I think Shannon brought up a great point talking about, the secondary stigma associated with the harm reduction workforce, you know, and that's and there's prejudice against okay, so someone comes into your office, right, and they're having chaotic use of methamphetamine and heroin, and through your interactions with them, they no longer do, but they have a manageable relationship with alcohol and cannabis. Have you not accomplished something in partnership with them that is just tremendous? I mean, it's clinical success. It's life-saving. It's splendid. But as we saw with when a young woman came out recently and talking about Cali Sober, Demi Lovato, we saw people from the recovery community just respond with so much derision and it was volatile at times. And I kind of understood that. We're all deeply in love with our culture. It saved our life. And this is cultural pride or whatever. I'm not excusing it, but I start to understand it a little bit. But then when you had addiction professionals who happen to also be in recovery, as many of us are, and I was seeing them respond that way, I had a big problem with that. And I included a little article I wrote called, Cali Sober or, something like that. But those folks need to revisit their practice boards that certify or license them and take a look at their ethical codes. They need to take a look at medical ethics of non-malfeasance, beneficence, justice, and autonomy. I think that the prejudice against harm reduction, the prejudice against people who use drugs, it's just deeply rooted in the cultural component of people from the 12-step community, of which I am a part and of which and from which I had biases towards harm reduction and towards people who use drugs and towards people who had returned to use, even though it took me nearly 20 years, to find a sustained recovery pathway. And in that process, also losing two of my beloved sisters to this as well. It was so deeply ingrained in me. And I grieve over that on the daily, and I try to make amends on that, on the harm that I caused, rooted in my cultural bias. Yeah, sorry, I went on for a minute.
No, it's really important, Donald, to get it's that deeply passionate and personal response that I think matters more than anything that we could say around this topic. That it would be the sort of collegial. We're at a conference and this is how we talk about it. No, I want us to talk about this in terms of how it is impacting us, right? So Yarelix, Shannon, what are you guys thinking?
Well, for me, one of the most important things that anyone ever said to me in working in harm reduction, and also I had a partner who was using like a lot, and it was really making my work hard, making my life hard, balancing harm reduction in my life and at home. And someone said to me, Shannon, harm reduction is a social science, like a social service. It's not a personal relationship guideline. And I think that when people say they don't like people who use drugs, or, they don't like harm reduction, it might be the ways in which harm reduction hasn't worked for them in their personal relationships, where their boundaries felt like they were being stomped on or something because they're being asked to uphold something that's really a profession and a job and an evidence-based intervention to, huge problems that are, integrated into our whole society. And I think that a lot of the hatred that I get from people about harm reduction is they think that the enabling factor, they think we're enabling people who use drugs because we're providing an evidence-based social service and compassion. But like someone asked in the chat, like about your parents, like, do you know people's parents? Like almost all the participants that I've ever been close with, like I know their parents' phone number and I'm like the person that can get them in touch with their child. But I understand why the parent couldn't do what I'm doing, you know? And that's, I think, where the people that I know that don't think harm reduction is cool is where they're like getting confused.
That is, I just had to, that's a lot to process, Shannon. It's that, I think it's really accurate though. I'm sorry, I'm just, I'm kind of working that through the gears in here. Yarelix, what are you thinking about this?
A lot of what was said resonates. I think what's coming to mind for me is, again, I started my work in harm reduction from a different perspective. It was mainly working with folks that didn't, well, some of them did have problematic substance use, but overdose wasn't a big issue in that community until I started working in I guess like institutionalized harm reduction at this point. Then I started working with folks, and it was through hanging out with them and like interviewing them that I learned about their life and what led them to where they're at, and like the barriers that they have to care and things like that. And for us, so I started working in harm reduction around 2015 when fentanyl started coming into the drug supply, and the numbers of overdoses haven't stopped going up. And so I think the conversation might have been different prior to that time because, fentanyl wasn't in the drug market, but now it's harm reduction is life or death. Like if we don't have harm reduction, if we don't give people naloxone, if we don't give people fentanyl test strips, if we don't try to advocate for a safe supply, people are just going to keep dying in mass. Like we had 90,000 people die last year, and that's unacceptable. That shouldn't have happened. So, I think we just need it at this point. There's no question about it. If we want people to live, because no life is dispensable, right, then we need to engage in harm reduction and expand it.
Really beautifully stated. That's wonderful. And I keep going back to Donald's original comment on this too. And, in many ways, again, my experience is similar. I don't know that I necessarily had the level of privilege, I think, Donald, that you enjoyed in being able to move into treatment and, how you entered recovery. Mine really was much more harm reduction based. And from the point where, from the 80s, when I started to use IV drugs, and at the same time we had an HIV/AIDS crisis that was exploding out of control, I can remember carrying those little Kodak film containers full of bleach. And at the time, you could purchase, syringes over the counter, so that wasn't an issue. But how we were using and sharing was. And because I understood that, it's, when I think about folks, and the LA Community Health Project is masterful at this, using our brothers and sisters who have, are in active addiction or who have dealt with active addiction to be the deliverers of opioid overdose and syringe exchanges. I mean, that's brilliant because that's the audience, that's the group of folks that we're trying to support. And it mattered. I'm here because of that. And I'm here because I didn't listen to the negative stuff that came out of my recovery community in a 12-step group. And I'm not throwing the 12-step community under the bus. In fact, what I would say is in 1997, when I raised the idea of using methadone in a NA meeting, I think most of you who understand 12-step programs would understand the response I got, which is led me to swear off anything but abstinence approach until I overdosed the third time on black tar heroin. And my partner at the time said, I don't care what you think, I'm taking you to this clinic because if you don't do this, I won't have you, and you will certainly lose me. So I've been embracing harm reduction since the 1980s. And here's what I'll say to my 12-step brothers and sisters out there, because I carried a big chip and a lot of resentment over this for a long time. But the truth is, I know that this wasn't mean-spirited. And what was happening was the only way we knew back then how to get people into recovery, how to keep people safe and abstinent. And the only additional thing I will add to my 12-step brothers and sisters is this. Thank you for really trying to save my life. I'm grateful that's what you were doing. And had you been able to accept me and start working the steps with me, set aside the fact that I was using medication-assisted treatment, just help me work the steps, my recovery may have been turbocharged and it may have occurred much more rapidly for me than it did. But I'm still grateful that the 12-step community is out there to support my brothers and sisters. It's really, really important. So I wanted to share that because it's important. Donald, did you have a comment?
Yeah, man, I got to jump up in that, because one of the manifestations of the prejudice against people who use drugs and people experiencing substance use disorder is the absence of informed consent, often around treatment and recovery support services and the supports to which we refer them. In particular, sending folks to traditional 12-step mutual aid societies when they're taking medications for opioid use disorder, and telling them, don't share all of yourself. Limit the connection that you have. Imagine having someone who practiced Judaism and the only church was a Christian church, and you're like, well, go get you some, take what you need, leave the rest. Don't let folks know that you're Jewish, right? I mean, it's insane. But you do speak to that for nearly 9 decades now, they have shouldered the entire burden of continuing care in our communities, but that is no longer the case. We have Medication Assisted Recovery Anonymous, and we have Harm Reduction Works. God bless Jess Tilley and friends like Megan Hetfield, who helped to blow it up across the country, man. So we have alternatives for mutual aid, and connection for me is where it's at. My recovery is connection, and then autonomy, and then purpose. And connection, autonomy, and purpose. And this prejudice, this stigma surrounding substance use disorder limits connection. And I got to throw it out there. I'm on a connection drive right now, and I'm so deeply gratified about the work of Gabor Mate and watching wisdom of trauma recently, and connecting with an organization out of Asheville, North Carolina called Seek Healing. And they're doing some splendid work, and it's just all about connecting folks. And that is also an alternative mutual aid group that is helpful for people who may have been in a 12-step community, but no longer fellowship, but are seeking that connection again, or people at the outset of their recovery process who may be looking for alternatives where they can be their full selves with people, full connection.
Wow.
Yeah,
I'd kill to have a group like that, just access. Honest to God, holy mackerel. Yarelix and Shannon, thoughts on this? Anything else to add?
Not really, not so much. I mean, I've never been in recovery, and I do not wish for sobriety. But I've also never needed to do that in order to live my life regularly. So I don't know, 12-step programs. I got a lot of friends who do it, and I also got a lot of friends who shoot heroin every day,
Shannon, there is nothing more powerful than your honesty. And I mean it. I think it just goes right back to what Donald was saying about connection and being authentic. And I'd much rather hear authenticity than BS. So thank you for being just who you are, because it's awesome. Yarelix, last word.
Well, on this topic, same. I don't have all that much to add either. Yeah.
Not a problem. Then let me get you to something that you might have a thought about. Are there, and I'm sending this right to you, Yarelix, are there resources from you, from your perspective, or even just sources of information that you refer others to, or that you use around this idea of, harm reduction in drug use and, reducing drug use or why people use? Where do you get your information, and how can others benefit from some of that?
Well, for general information around harm reduction, the National Harm Reduction Coalition is great for that. For general information around drug policy and its history and the harm that drug policy has done in our communities, you can go to Drug Policy Alliance's website, drugpolicy.org. I think there is a lot of helpful information as well with Dance Safe, an organization that gives very transparent information about what drugs are, how to use them safely, what the effects are, what the negative effects are, as well as selling harm reduction testing, like drug checking items. I also really like the work that the British Center for British Columbia Center on Substance Use is doing around drug checking services, where people can bring samples of their drugs so that they can get them like drug checked or tested or whatever, like fentanyl test strips, and with a machine, so that people, especially now when we have such a contaminated drug supply, folks can know what's in their drugs and then plan accordingly on what to do. So if they know that there's something that's adulterated in their drug, then they can use less, so that they are less likely to have an overdose. So those are just some of the general places that I would recommend folks to start. They have good harm reduction and drug policy information.
Fantastic, Yarelix. Thank you, because, and I'm coming to each one of you with this question, but I'm gonna, with Shannon, there's another question in here, and I want to make sure I'm doing this right. I got to find the right one, because when I looked at it, I thought, oh my God, that's perfect. And maybe I overlooked it, and I apologize. So I'm sure that I will find it. And again, I apologize for kind of setting you up and then kind of pulling the rug out from underneath you. But
Right.
Let me check in with you on this. How does harm reduction work with parents who are actively parenting their kids?
Yeah, the parent question.
Or is there such a thing?
No, I mean, honestly, like I'm not a parent, but I know a lot of parents of people who use drugs, their children use drugs in ways that they can't handle. And honestly, and it's going to be kind of brutal, but I'll speak from like the ones that I know who have lost their children and their regrets or lack of regrets, because I feel like that's where we can learn the most about our current ability, because this stuff is always really hard, and it's like hard on the daily. You never know if you're doing it right. You don't want to push people away, but you need them to stay alive and in your life. And I've found that people always just really value the time that they get with their kid if their kid does wind up dying of overdose, which is so common, that remembering the good times is always what happens. And understanding that just pursuing good times with your kid is basically, I think, the best thing that I could recommend to do based on that. And in terms of the harm reduction approach, I'd say value your local needle exchange, value your local harm reduction providers that are helping your kid, and don't promote criminalization of drug dealers, etc. Work towards decriminalization, because decrim will help, treatment options will help, life-saving interventions and all that occur. And the criminalization of drug use and interventions isn't helping anything. It's killing people's children all the time.
Yeah, I'm a parent of actively using children, and I'm a parent in recovery. And it is, it's a challenging, to me, for me, it's all about harm reduction because I recognize that as a parent, my children are, they're grown adults. I can't put them in timeout. I don't have, that's not my option. And I don't want them to die. And I do want to remember good times. And I've dealt enough with parents who have lost their kids over, opioid overdose or, other overdoses as well. And
I see that I don't want to
Go
interrupt
ahead.
you, but I see that
You're
we
good, Shannon.
answered the question wrong because it says I'm asking about parents who are using and parenting their kids.
Okay, you got a
So-
different approach? Because thank you for that.
I mean, for one, I would say give your kids Narcan and teach them about overdose because I've definitely known some kids that have watched their parents die and didn't know about Narcan, and we brought it up there a little too late to the family. But you, Stephen, I defer to you or someone else for that because you're a parent.
Well, thank you. And I'm with you. Teach your kids how to use Narcan. Let them understand and teach them the truth about drugs. Give them as much information as you can. Model recovery, model harm reduction if you're in active use. Those are the things that I did as a parent in active addiction. I've also lost a son as a direct result of the activity that I introduced him to. I certainly didn't put a syringe in his hand, but he saw me with one enough that I think he thought that was okay. And he overdosed and died 4 or 5 years ago now. It was my stepson. So I've been on both sides, and I wish today that I would have been more, I think, assertive around harm reduction because I wasn't going to be able to get him to stop, but I may have been able to save and protect his life. So there's some guilt and there's tons of regret there as a parent in recovery. Yarelix, any thoughts here?
The Urban Survivors Union has done a lot of work around this. I can put the link in the chat. I know that, and the Drug Policy Alliance as well has just done work around, particularly around mothers who are using when they're pregnant and then when they give birth, and all of the criminalization around them and having their children forcibly removed from them, and just seeing from a science perspective the really negative consequences that children have because the children just need their parents, and oftentimes parents are being criminalized as opposed to being supported and given treatment that feels right for them, or given housing, or the basic services that they need, or basic living things that they need. So yeah, I think from a harm reduction perspective, we just want to support folks as much as possible. We don't want to take the parents or the children away from their parents because that just leads to more anguish from both ends. But it is a complicated system because of the way that the laws that we have, like around social work and these things are coming from a place of criminalization as opposed to compassion, and figuring out how to fund better services as opposed to just sending people to jail.
Yeah, really, again, well stated, Yarlitz. Donald, last word on this.
I hate to leave it. I hate to leave this discussion on such a, I know rubber hits the road when we're talking about people who are parenting. I practiced harm reduction when I was experiencing chaotic use while I was a parent of young children. And it was much easier for me with alcohol. Alcohol was legal and it was regulated, and I knew what I was drinking, and I bought it in a safe place. That was not always the case with the illicit drugs that I was using. That's when the danger ensued there with that culture. But I practice harm reduction, and that also speaks to the fact that when people are experiencing substance use disorder, despite the fact that this hijacked brain theoretical model has helped us to battle the moral model to its death, people aren't zombies when they experience substance use disorder. We're still human beings. We still have discretion, and then it's nuanced. And And compassion is the thing. If folks meet us with love and compassion, where we are, want us to live to see another day, that's very appealing. And if you happen to be in recovery, I may want to come get what you got. You know what I'm saying? But, if you shut me out, I'm alone, man. And you know what's going to keep me company? Alcohol and drugs.
That's right.
Facts.
Yeah. So you guys, this is a conversation we could spend all day. And one of the things I've just been going through the chat, and as I've listened to everybody, it's just a really interesting set of discussions that are occurring in here. And the reason that I raise it, is because it is hitting so many different areas. And I think that's what Shannon made this point early on, that harm reduction isn't just around, and I'm paraphrasing here, but it isn't just for substance use. We do harm reduction in all kinds of, that's why we have seatbelts, right? I mean, it's harm reduction. That's what a seatbelt is, right? So, I mean, it just looks at, as I'm going through the chat, so much. There's a conversation in here about, there's so much focus on opioid SUD and all of the options for that population. What is being done for stimulant users, and why is cannabis or marijuana rarely talked about? And all of those things are, issues that folks are curious about and talking about, right? There's a comment in here about, here's a person, and I think this is the same person that wrote the last post, but she says, by the way, I'm a 12-step person who uses cannabis to stay clean. I don't hide that. I need to be transparent, and I need the 12 steps. It's my recovery, and that's my shield. And, Lori, thank you for your honesty. I believe it's Lori. I can only see LAUR ... and I apologize if I got that wrong. But, thank you for your honesty, because it takes an awful lot to stand up and say, I use cannabis and I'm in recovery. Not everybody can do that, make the comment or make the statement. So that honesty is really important. Susie, or Suze, S-U-Z, sorry, says the most difficult critic is the parents wrapping their minds around the harm reduction model. And, I mean, everybody here is nodding their head in, yep, that's accurate. Some prescribers, this is from Yarelix, some prescribers can work with their patients and prescribe prescription stimulants, I'm one of them, to support their use as a safer option than what's on the street. There should be more options, though, since a lot of clinicians won't do this. And let me just say, to dovetail with what Yarelix said there, I'm one of those people who receives both a opioid prescription every month, a stimulant prescription every month, and a prescription for my bipolar disorder every month. And those medications for me have absolutely stabilized and changed my life. But when my physician was preparing to give them to me, here's what he said: Stephen, if you ever leave this facility for treatment, you must take a copy of your notes, because no other doctor is likely to do this for you because of the stigma around it. And so we have a lot of work to do, folks. I want to thank the three speakers today. Folks, I work with great people, and I'm always humbled at the expertise and the brilliance of folks around me. And I know sometimes it feels like platitude, but it's not. I know we're at the top of the hour. Before everybody runs off, please be aware a link to a satisfaction survey is going to pop up when we close this meeting. Take less than 3 minutes. And I hope that you will give your feedback on our presentation, because your comments and suggestions are darned important. It's why Recovery Live is the way it is, because we listen to you. Also, please consider reaching out to request training and technical assistance from us, C4, anytime at training@c4innovates.com. Sign up for our newsletter. Thank you for joining us. I hope to see you guys in July. And to my speakers, awesome job, guys. Thank you. Have a great Thursday, folks.